up. This. Okay, that's done. I have to double check everything. I'm like, is it Tuesday? I don't even know anymore. Anaya, Tori. I had a request in an email for one of our students. She decided she does not want to present. She's going to therefore take the 0 on the delivery part of the presentation, and then it's entirely you guys' decision. If you haven't yet presented and your presentation is coming up and you want to take a 0 on the delivery, that is entirely your choice, and I will support that, but just know that if you do that, you take the 0 for it. So that's fine. I just wanted to say that for anybody else that might be considering that. Let me pull my stuff up. Okay. So quiet in here. Stresses me out. Huh? I was just saying it's quiet and it stresses me out.
Let me ask you, are we gonna have one of the dichotomous keys on there?
Yes.
And you know how like you were pointing the arrows, like this is catalase and it's aerobic.
Yeah.
Are we gonna basically need to like know what is what or whatever?
So
or just be able to go all the way down it to figure out what it is?
So I haven't finalized. I have a couple choices. I'll probably have one that I'll give you like a chart, like the whole chart, and you'll just have to find them.
Okay.
The other one, I'm probably just going to give you like, you have a gram-negative organism that is, urease negative and phenylalanine positive and whatever. What organism is it? And not give the full chart. Usually when I do those, I have information also in that list that is not even on the chart. So you'll have to like know what information applies to the dichotomous key. Yeah, if that makes sense. But you will be given the dichotomous key and you will be given the information you need to answer it. So it's just a matter of plugging it into the key. It shouldn't be too difficult. Yeah. What's up? Okay.
Would that be also like lactose and sucrose? Because it's a sugar.
So this was for asking about the TSIA, and this was another one of those ones that I literally updated this one, and it wasn't the one that is available. This was the one that I handed out. Remember how there's like extra sheets on the, I don't know if you can remember, but yeah, I updated the question. So it's talking about if it's positive for glucose fermentation in TSIA.
Oh,
Did that make it a lot easier? It should. Yeah, TSIA, glucose fermentation, then obviously I feel like the PR carbohydrate fermentation tube with the Durham tube in it, the glucose fermentation for that should be positive too. So that's what that's talking about. Yeah, it's not meant, like I said, I had reworded that and I had handed it out, but you guys were busy. So that one was one of those ones that if you didn't see it on your desk, then the update was not apparent, and that is fine. That's what I'm here for. Tori. Yeah. So no, it'll be from exercise. It's exercise 12 was the actual like experiment for, the results would have been on 13, but that'll be that PR fermentation one. Okay. And then we have, yeah, we're getting there, guys. Forget about that. Here. For which one? The lab? That it's that one question. Yeah. So no, that one's not available on there. It was just one that I handed out in the lab. Yeah, it literally only just says glucose fermentation for the TSIA. What other glucose fermentation tests basically did we do?
Okay, so when you change the word, so that's just the
yes, that one. That is not a B, that is a 6. Oh my gosh. Yes. Okay. Yes, and then download. Let's do it. All right, so we'll get started with our presentations. I'll share this on Zoom. Over. We'll start with the presentations. Again, I don't know why I can see your updates on Canvas and sometimes I can't. So if you had an updated version of your presentation that doesn't pull up for some reason when you come up here to present, know that I will take a look at that in your points if you had any missing. And otherwise, you're just going to be graded on the delivery portion today. So remember that, because I don't know why. Some people had updated stuff and it just didn't populate when I download it. So we're just waiting on this. Okay, cool. Share. Great. Yeah, I see it like this is another one I see it on like when I open it on Canvas, but for some reason.
Yeah, it's the Canva thing when you transfer it to a PowerPoint.
Yeah, I don't know why it does that. That's my apologies, but
no problem.
it full screen. Alrighty, it's all you.
Well, it doesn't say it, but my presentation is on toxic shock syndrome, a disease of the circulatory system. So I was interested in presenting on this because I would always hear growing up not to use tampons because you'll die. And I never knew why that was. So I thought that I would look into that. So it is a form of septic shock. If you've heard of septic shock, it's just a very severe form of that. And it is linked to the use of highly absorbent tampons, but anyone can contract it through the bloodstream or any type of open wounds. So the etiological agents are Streptococcus pyogenes or Staphylococcus aureus. They're differentiated by calling it streptococcal toxic shock syndrome or non-streptococcal, And it's pretty known that streptococcal is going to be the more severe version or more fatal. So an important virulence factor to note is the super antigens that both of them have. And it has something called toxic shock syndrome, toxic 1. Toxic shock syndrome, toxin 1. Okay. So essentially, this causes intense immune response or cytokine signaling. They call it a cytokine storm. And it's going to cause systemic inflammation, a lot of tissue damage, and lead to organ failure when your immune system is in overload like that. And then they also share some of the same adhesins, toxins, enzymes, capsules, and they're both resistant to penicillin. Can't see it, but this is how this is transmitted. It's transmitted through contact. So if you have any open wounds, any type of surgeries happening, infections that are already in the body, you're at increased risk for toxic shock syndrome. Both these bacteria also create biofilms. So if there's a foreign device in the body, you're more prone to toxic shock syndrome, and also through foodborne illness. So the main signs and symptoms are pretty similar to most other diseases: fever, flu-like, hypotension, of course. It gets a little different when you get to the rash formed on the hands or the palms and the heels. Also tissue necrosis, which is the dying and it turns black and gross. Eye infections, organ failure, and skin peeling are all known. So it's often mistaken for sepsis, of course, because it is a form, but toxic shock is much more severe. Scarlet fever, measles, endocarditis, necrotizing fasciitis, like the symptom of necrosis, is sometimes known in that way. Meningococcemia, heat stroke, or hemorrhagic fevers. All those share symptoms, but when it shares all of them together is when you know that it's toxic shock syndrome. It can be tested through the major ones that we did in class: the PCR, ELISA, and Western blotting for Staphylococcus aureus. And for streptococcal version, PCR and toxin assays are good for identifying those. Also, blood cultures and tissue cultures for the presence of those bacteria. Lab tests for liver and kidney function help to identify it because a lot of times your liver and kidneys will not be functioning well if you do have this disease. And coagulation studies show a lot through, if you saw on the virulence factor slide, an enzyme associated with staph is coagulase, so the blood will be more clotted or thicker. And also complete blood cell count to show high or low white blood cells in the body. This can be treated mostly through antibiotics. There's different ones that perform better for staph or strep, but a lot of these are used in conjunction with each other. Also, things to help raise blood pressure, increase oxygen intake, and support for failing organs. Surgical intervention can be used for tissue necrosis, just debriding the dead tissues, and intravenous immunoglobulin will help to fight against the toxic shock syndrome super antigen. And that is all I have.
Great. Tori's not here yet. Yes, okay. I was like trying to scan everybody to see who is here. And I opened it, but I guess not. Downloads. You did Rift Valley, correct? Yeah, so I guess you had come in a little bit after, but sometimes the updated versions, I don't know why, but they won't download up onto my computer. So you'll only get graded for like the presentation, I guess the delivery today. I can't, I can see it on my computer, but for some reason it doesn't populate on here. So we have this, and that is literally all I can download onto here. So it's not your fault. You don't get points off for that, but yeah. We want to like add in any commentary to what did you think, please do that. But yeah, that's not something that unfortunately Canvas wants to cooperate with today. So.
So today I'll talk about Rift Valley fever in animals. So this is a disease which is quite common in the country I come from, which is Kenya. So Rift Valley fever is a zoonotic mosquito-borne disease, and it's also a viral disease, and it's common in ruminants, especially wild and domestic animals. It causes abortions in mature animals and deaths in young animals. And in humans, it causes influenza-like symptoms. So it's present in sub-Saharan Africa, Arabian Peninsula, Madagascar, and some Indian Ocean islands like Madagascar. Outbreaks cause economic losses, especially deaths of animals, and there's limited trade of livestock because obviously the livestock keepers can't sell diseased animals in the markets. So Rift Valley fever belongs to the family Flabovirus, to the genus Flabovirus, and it's a single-stranded RNA virus. So the factors which make Rift Valley fever pathogenic, it has a non-structural protein component, and this interferes with production of type 1 interferons, which are antiviral. And interferons are basically proteins which help the immune system to fight disease. And they also have nuclear filaments that damage the cell cycle and also cause DNA damage and apoptosis, which is cell death. So epidemiology, it's believed to have originated in the Rift Valley region, that is in Kenya, and it's spread out throughout sub-Saharan Africa, so all the countries in red, and all the way to West Africa, Egypt, and the Middle East, like countries like Iraq, Iran, Saudi Arabia. The main cause in animals is mosquitoes, and especially after a period of heavy rainfall and flooding, which offers conducive grounds for the mosquitoes to breed. And transmission is through bites from infected mosquitoes. The causes in humans, mainly tissues and fluids from infected animals and aborted fetuses. Aerosols from infected animals during slaughter, and less common is mosquito bites. So humans who are most at risk are those working in the animal production industry, like farmers, farmhands, slaughterhouse workers, and veterinarians. So this shows how the transmission occurs from animals, wild ruminants to humans, and yeah, so the mosquito is the main vector that transmits the disease to the wild ruminants and also to humans. So the clinical symptoms, mostly in ruminants, cattle, sheep, goats, water buffaloes, and camels. It's more severe in young animals compared to older animals, especially in lambs more than calves. Young animals have a high fever of about 42 degrees centigrade, that's about 108 degrees Fahrenheit, and they have lethargy, low appetite, diarrhea, and death. Older animals have weakness, fever, lacrimation, nasal discharge, bloody diarrhea, reduced milk production, and abortions. So abortions is the main clinical sign in mature animals. In humans, it causes the flu-like symptoms, which they have headache, muscle pains, and weakness. So the post-mortem lesions are mostly seen in the liver, and the liver appears enlarged and it's friable, especially in the livers of aborted fetuses. And necrosis, liver necrosis is the most significant postmortem sign. And there's also a condition called melena, which is dark dark brown intestinal contents. So that means there's bleeding within the intestinal lumen. And also there's enlarged edematous spleen and lymph nodes that have petechiae. So you can see the liver here, it appears enlarged and it has rounded edges. And if you look closely, you can see it has the bleeding spots, which are called petechiae.
My name. What's Melina?
Melina?
I wrote it in a different form. Is that how you pronounce that word?
Okay, that's how I say it,
Yeah,
Melina.
I'm not sure. I don't know that word very well. I would say it probably is pronounced like that. You're famous now.
So the main diagnosis is from clinical symptoms, and abortion in mature animals is the main characteristic diagnosis, especially after rainfall, and mortality also of young animals and concurrent human influenza-like symptoms. Histopathology, when you see necrotic liver necrosis, that's just like the darkening and the rotting of the liver. Also, you can do PCR, which is amplification of the viral nucleic acid, which is the RNA. And ELISA, there are ELISA, commercial ELISA test kits that test for antibodies, this through the indirect method. And immunohistochemistry, the virus is diagnosed in organ tissue like the liver through stains. So since it's a viral disease, there's no treatment for it, and treatment is geared towards symptomatic, treating through the symptoms, and fluid therapy is usually administered, and to just rehydrate the animals, and antipyretic drugs to reduce the fever. Control and prevention, the main prevention is immunization, especially of young animals at 6 months of age, and this offers lifelong protection. In mature animals, especially pregnant animals, it's advised to give formalin inactivated vaccine, which is safe for them. And for people working in the animal production industry, like the farmers, veterinarians, slaughterhouse workers, they're advised to put on protective gear, that's the gowns, the goggles, gloves, especially when they're investigating animals that are suspected to have RVF, or also aborted fetuses, or when collecting samples. Okay, that's it.
Excellent. So a little disclaimer is that I, in graduate school, started all my work on Rift Valley fever virus and then switched to Crimean Congo hemorrhagic virus. They're very closely related. So I have a pretty good background in it. I will say this for Rift Valley fever. It's, of course, like in the presentation, one of those diseases that's found mostly in Africa, especially sub-Saharan Africa. But there's a huge concern about it transmitting here to the United States because we have livestock here, and it is highly abortive in livestock and is extremely high mortality rate for like younger livestock. So that could severely handicap our like livestock industry, and therefore our industry as a whole here in America, since we rely so heavily on it. So we have to really heavily screen for that when we have incoming animals, and like when you go through customs, like that's why that stuff is so important to keep it out. It is concern for like bioterrorism as well. But okay, you ready? Okay, so you'll use the arrow keys right and left for this one.
Okay. So malaria is a deadly disease transmitted by mosquitoes that are infected with parasites. When the insects bite you, they're infecting you with that parasite into your blood circulation, essentially. It is a protozoan parasite rather than a virus or a bacteria. if not treated, it can lead to serious health issues and sometimes even death. This is just the taxonomy of it. They're from the Protista kingdom, more specifically the genus Plasmodium, and it does have several different species that infect humans, and this is kind of a list of them. So that first one is the most severe form. The majority of people get it. Well, the majority of people that have it, it's this. Vivax causes relapsing malaria, which just means even after transmission, or not transmission, treatment, you can continue to still get it. It can last from weeks to months to sometimes even years. Oval is just a less common version of Vivax, which is the relapsing. Malariae causes a milder form of malaria, and Nalesi is primarily zoonotic malaria, and that just means it's mostly in animals. Humans can get it, it's just highly unlikely or less likely. Okay, these are the different species that we talked about, and then the different stages of which it starts to form. So that ring stage, that is the first stage that it infects the red blood cell. It is called the ring stage, mostly because it's shade. You can't really tell in this picture, but it's literally like a ring, almost like an oval or like a crescent moon. The tropocyte, that's the second stage, and this is basically, you can kind of see it's a little bit darker. That's just it basically eating and feeding and growing on the hemoglobin that's inside the red blood cells. Schizont stage, this is when it's starting to actually burst out of the cell, as you can kind of tell, it's spreading, and that's when you'll actually start to feel and see signs of malaria. You typically don't see signs in malaria. You can't just look at someone and tell they have malaria unless they have like a very advanced version of it. The gametocyte, this is basically, it's out of the red blood cell. It's actually transition form to its sexual form, which just means that is going to be taken up by the mosquito. So when the mosquito bites an infected person, that's the organism that it's going to take back up to continue the cycle and reinfect more people. The genome details, the Plasmodium genome is comprised of multiple different chromosomes. It contains around 5,300 genes. It's complex. It reflects the organism's adaptation to various hosts and environments, which just means it can change its form, basically go through genetic mutation to whatever it's going in, whether it's in the human or whether it's in the mosquito. And sometimes this can even lead to problems as far as like if it has a genetic mutation that per se is like resistant to anti-malarial drug, that's going to cause drug resistance, and that's not something that you want to happen, of course. The morphology, it exists in several forms. So the sporocyte, this is the infected form. So this is going to go straight to your liver. That's what's going to infect you, basically. The merocyte is what it's going to turn into. And that's going to, once it matures, it'll be released back into the bloodstream and infect the rest of the red blood cells. And the gametocyte, that's what we just talked about. It'll be taken back up by the mosquito. Evasion of host immune response, antigenic variation allows Plasmodium to evade detection. So this is just basically it creating different surface proteins to keep it from attaching to receptors, so that way it initially is hiding from it. And then invasion of red blood cells, specific proteins on the surface of merocyte facilitate RBC, which is essentially the same thing. It's just different ways to hide from any kind of invasion of it. Sequestration, infected RBCs adhere to vascular endothelium, preventing their clearance by the spleen. So this process, it means that it's literally going to attach to the wall of the blood vessel. So your spleen it's designed to clear out any kind of infected or dead cells. And if it's attached to the wall of that vessel, it's not going to detect it, it's not going to see it. So it's not going to push it out of the spleen, and it's going to just continue to grow and multiply. And then you'll get to splenomegaly, which is basically enlargement of the spleen. Metabolic modulation is production of factors that manipulate the host cell response and induce inflammation. Vector-borne transmission, primarily transmitted through the bite of an infected female Anopheles mosquito. So this is just the mosquito that you're typically going to get malaria from if you're a human. Other routes, that's just from mother to child. So just from birth, if your mom has it, and that bloodstream is going right into blood transfusion or shared needles. So if you're getting a transfusion from someone with malaria, of course, you're going to give it to shared needles. Geographical location, high prevalence in tropical and subtropical regions. This is just because they have a high humidity and the larva needs to be able to grow, and they have ponds, swamps, the right atmosphere for them to survive and have a good socioeconomic status, limited access to preventative measures in healthcare. So this just means like in places that have limited access to healthcare or the preventative measures to treat malaria, or even the limited access to knowledge of what to do or what it is. Immunocompromised status, people with weakened immune systems are more susceptible. So people with like new immune systems, like young children, or reduced immune systems, like pregnant women, are definitely at a higher risk. Previous infection, individuals with a history of malaria may have partial immunity, but that varies widely. So what this means is, like we talked about at the beginning, there's multiple different strains of malaria. So you could be immune to one strain and still catch another one. So while you have had it before and you're immune to that, you can still be reinfected. These are just some of the symptoms. This is what I mean by you can't really tell unless it's a high form of it. You get fevers, chills, sweats, headaches, nausea, vomiting, muscle pain, fatigue. And this right here is just a diagram of how the process of it going through with the mosquito, and then going through the spleen to the bloodstream and then back to the mosquito. Anemia, splenomegaly, that's the enlargement of the spleen. Jaundice, that's like yellowing of the skin and eyes. Those are in severe cases. Dengue fever, this is a type that will be present with not a very high fever. There's not really a fever there. While the typhoid fever, that's like a long duration of it. Viral hepatitis. That one is where you'll see the jaundice. That one is where you'll see the jaundice, the yellowing of the skin, the yellowing of the eyes. This rickettsial infection, that's going to be present in rashes. You can see that one on your skin too, so that's a visible one. The ways that you can diagnose it, the microscope, blood smears, RDTs, that's probably the most easiest, but it's not very high sensitive, so it's not like early detection like you would see in the PCR. So PCR is probably the best form to detect it because it can tell you what type of plasmodium or malaria it is. It can tell you treatments for it. It can basically tell you anything you need to know. ELISA is not really used for it, but it can be. This is just the diagram of an RDT taking any kind of like finger stick or blood sample. And that's the normal cell, and that's the infected blood cell with the parasites just taking advantage of it. Okay, so ACTs is the first line of treatment. Chloroquine, this is basically going to stop the enzyme that takes heme and transforms it into hemosin. So basically that's going to stop it right at that point, where Primacune, that is the prevention of relapse, which is going to happen in the spleen. So that drug detects it into the spleen before it gets there to prevent relapse. Palliative care, this has nothing to do with the target of the actual parasite itself. It's just supportive care, fever management, hydration, keeping your fluids up, IVs, all that good stuff. Vaccines, this malaria vaccine, I think it's the only one that they have, but it was the first one. This basically attacks sporozytes before it even gets to the spleen in general, like stops before anything even happens. Is what that vaccine does. And sporozytes is the one that turns into merozytes that goes into the bloodstream. Malaria has been recognized for centuries, with ancient texts describing the symptoms. The connection between mosquitoes and malaria was established in the 19th century by Sir Ronald Ross, World Health Organization estimates over 200 million cases of malaria annually, with significant mortality rates, particularly in sub-Africa. Efforts include mosquito control, just stuff that you can do at home, putting up mosquito nets, just protecting yourself from even the possibility, essentially. Rapid diagnosis and treatment access, future direction, research into new vaccines, anti-malarial drugs, gene editing technologies, so the CRISPR. So they're actually engineering mosquitoes to be immune from the Plasmodium gene in general, to try and just keep it from circulating and rehappening from starting with the mosquito itself. So that's what the gene editing, the CRISPR, is coming into play that we talked about in class. And then, yeah, and that hopefully will keep it under control and potentially eliminate malaria. Conclusion, malaria remains a significant global health challenge, but advancements in research, treatment, prevention strategies offer hope for reducing its impact in affected regions. Continued vigilance and innovation are crucial to combating this ancient disease. So just keeping your knowledge up and being aware of what's going on. And that is all I have.
So the student presentations are out of the way. Does anybody have any questions for me about the material, tests coming up, anything like that before we get started with the lecture? Good. I like to not have to answer questions, but I hope that you guys are coming to me with questions if you had them. All right, so chapter 21 is dealing with the cardiovascular system. We've already had introduction of some diseases that can affect our cardiovascular system and lymphatic system. So just a brief, summary of our cardiovascular system, its structures, how it works, as well as the lymphatic system. We should know that the heart pumps your blood, arteries are going away in general, and veins going back towards the blood in general. Back to the heart, in general, and that our capillaries are going to be where our exchange of the gases are going to occur from the tissues. If you want to know more about the details of that, and there are plenty, then you guys will learn about that stuff in anatomy and physiology. But anyways, the lymphatic system, we also learned about this already in chapters 15 and 16. But we know that this is going to be moving fluids from the extremities back towards the heart, and it includes all of your vessels for the lymphatic system, your lymph nodes, and any associated tissues like the spleen and associated lymphatic tissues that function like the lymph nodes, like your galt, malt, and salt, and all of that. As far as your defenses for the cardiovascular and lymphatic systems, cardio should itself not have any sort of microbiome whatsoever, another sterile area of your body. But having said that, both your cardiovascular and lymphatic systems have very high concentrations of white blood cells, how they move around in your body. So of course, they're going to be present there to help protect your body from infection, which is a huge, huge plus, because you don't want your cardiovascular system spreading infection around to other tissues in the body. This is a huge difference when we look at the CNS and how it has a sterile environment, but it doesn't have a very strong immune system in place. It's actually dampened on purpose for that immune privilege aspect, whereas the cardiovascular system might be sterile, but is definitely not an immune privilege site. We have a very high reactivity of our white blood cells in these areas. We have our adaptive immunity, we have our innate immunity, and our phagocytes, all of them being fully active in these areas. So coming back to these terms that we have kind of introduced previously, the emias. So here we have microbes essentially setting up house in your bloodstream. If you have any viruses or any viral infection in the bloodstream, that's viremia. This also includes viruses that would cause meningitis. You're usually going to have dissemination in the blood as well. We have fungemia, fungi in the blood, and bacteremia. If you have any bacteria in the blood. There shouldn't be any at all. So if there's any in there, it's bacteremia. Once they start to establish an infection within the bloodstream or the lymphatic system themselves, it's septicemia. So they're actually flourishing there, and their presence can lead to immune reaction, causing shock, severely decreased blood pressure, and can eventually lead to death as a result of that. So both of these are considered to be closed systems in a sense because we're just recirculating everything back and forth throughout the whole body over and over again. We can have transient microbes, but the white blood cells should be maintaining sterility as long as you don't have true infections taking hold. So our first example of a cardiovascular disease will be COVID-19, which I know we traditionally think of as being, you know, a respiratory disease, but it's not that simple. Sorry, my throat is really dry. So COVID-19 is caused by the virus SARS-CoV-2. So that's the virus name. There is another SARS virus, SARS-CoV, that's it, that causes SARS. And the reason I'm bringing this up is because if some of you are younger, you might not realize that SARS and COVID are not at all the same thing. SARS is a respiratory disease that appeared in the early 2000s and pretty much disappeared in 2003. We do think that perhaps SARS-CoV-2 is potentially an engineered virus that got out of Chinese laboratories being developed potentially again for bioterrorism use. That's kind of on the edge of being a conspiracy theory, but kind of not really because there's a lot of evidence to support it, but we'll leave it kind of there in that vague area. And that also reminds me, I wanted to bring up before we started the lecture, but as far as conspiracy theories go and scaremongering, because, you know, I like to do a little bit of scaremongering in this class to have appreciation for the danger of the diseases. If you guys are not following the news right now, you should be, because right now, just to clarify things, our President Biden has approved the use of long-range missiles in Russia. It's our missiles given to the Ukrainians for use against Russia in an area of Russia known as the Kursk region, where Russia has amped up their troop population with North Korean troops. And if you guys don't think that's World War III coming, I'm not kidding. You really should actually legitimately, this isn't scaremongering. So that's why I'm bringing it up if you're not keeping up with the news, so you're not shocked if things start steering that way. We all hope that'll get dampened down, but Putin is not happy. And he's friends with North Korea, Russia, North Korea, and China are all bedfellows. And I don't know if you guys know this, but if you order from Shein or Temu or pretty much buy anything ever online anywhere, including Amazon, it's coming from China. So if they shut down any imports into the United States, there's going to be a really serious panic probably following that, including inflation, because we're no longer going to be able to offer the prices that China can offer for things. I'm bringing this up just so we're aware. I don't want you guys to get lost in it, so you can be up with everything. If World War III, and I say World War III just because this doesn't just involve us versus Russia, right? This is Russia, North Korea, then probably China. The United States is part of NATO. Putin's responses were to NATO, and because we weren't the only country offering aid for Ukraine, obviously. And already Finland and Sweden have cautioned their populations to start stockpiling in preparation for war. So I'm not kidding. We're talking about Finland and Sweden. So I'm bringing it up because if you're not following the news, this isn't the time to bury our heads in the sand. I'm not saying you need to go home and start, creating bug out bags and all this, but maybe just be informed. That's all. But this reminded me of that because SARS, and whenever it first came out, everybody thinking it was bioterrorism and everything. It's related to SARS, and we thought SARS was bad. Believe me, I was there. I was an adult during that time. And so I remember that, everybody being afraid that SARS was going to come to the United States and people would be sick and have all this death and everything was going to be so bad. When COVID came out, 20 years later, and it ended up being worse. I don't think anybody was expecting that. I mean, clearly we weren't. Nobody was expecting that. So better to be prepared and aware of things. So this is a virus, SARS-CoV-2, causing COVID. This is a virus that gets into cells using this particular ACE2 protein on your cells. You're not necessarily going to get tested over that, but the reason it's important is it's found on almost all of the cells in your body. which is why this is a cardiovascular disease, because it can affect so many tissues and is transmitted within the bloodstream as a viremia to other tissues in the body. We have different variants of COVID that are out there, Alpha, and then more commonly and more popularly known are Delta and Omicron. Omicron is still probably the most widely diagnosed version. Both Delta and Omicron are more contagious than the original. They're both more deadly than the original, technically. So their virulence factors are much stronger, but we're more protected because of the vaccine immunity that we were able to develop before things got further out of control. You do have respiratory symptoms with this, of course, but you also have quite a great deal of other symptoms that can come along with it. That could be our neurotropic symptoms, like not having the sense of smell or taste and having headaches and other cognitive decline, leading to dementia, for example, and all sorts of presentation of signs and symptoms everywhere in the body. Up to a third of infections were considered to be asymptomatic. It's probably more than that now that we have great success of the vaccine. And then again, most people are going to have mild infections, especially since the vaccine. Most people aren't having a cytokine storm effect like what we were seeing putting people in hospitals in the very beginning of the introduction of this virus into our population. We've already discussed our vaccines, so I'm not going to go into too much detail here, but they were very new, novel introductions of vaccines as far as vaccine types that we had previously. Yes. I don't know. I feel like it is. Let's see if it says on here, because that's a good question. I won't necessarily test you on it, but I just know that it was on here. Here it is. Positive sense. So yes, it's single stranded. But so yeah, positive sense, and you could technically read it as mRNA when it gets into your body, which helps with speed of that virus growing in the body. I knew it was RNA, but yeah, good question. All right, endocarditis. This is a different disease now. We have inflammation of the inner lining of the heart. This doesn't necessarily have to be an infection in and of its own. We can have this as a secondary aspect to infections as well. This can be acute or subacute and leads to damage in the heart tissue and the endocardium itself. That inflammation can lead to all sorts of symptoms associated with that, which we'll talk about in a moment, usually introduced by vascular trauma, so literal, actual physical trauma to the vasculature, or circulating immune complexes, like we talked about with our type 3 hypersensitivities. And you'll have fever, anemia, and then heart symptoms as well. We also have, that's pretty common in the acute phase. You can also have presentation with side pain. That's usually associated with the spleen, being affected by the cardiac side of things. Then we have the Janeway lesions and the Osler's nodes. These are little spots that can develop in the calloused areas of the skin, in particular the hands, as well as the spots that can develop under the nails. So it's like if you ever slammed your fingernail in like a door or something and you get like a little blood spot under, and it sort of streaks out as the nail grows out. Well, you get that, but without having to slam your finger. So it's usually from the inflammation causing damage in red blood cells that we'll see accumulating in those extremity areas. Subacute endocarditis, you can have a little bit more muted presentation and progression of the disease, but we might have enlarged spleen. Again, that would help with presentation of that side pain that you would have. Clubbed fingers and toes can also occur in conjunction with the subacute version. If you guys don't know what clubbed fingers and toes are, I mean, and this isn't me trying to be rude, but I have relatively normal fingers. They're not clubbed is what I'm trying to say. So the average person having fingers that we would consider normal. Clubbed fingers are when you have that rounding of the nail, and it's like sort of rounded at the nail and the finger, and it creates that look to it. That's a clubbed finger or toe. That usually is going to occur when you have some sort of metabolic issue or something like endocarditis. That's not a normal presentation of fingers or toes. So if you know somebody that has clubbed fingers or toes, it can be a genetic presentation just normally, but it's usually associated with metabolic issues or endocarditis. That could be things like malnutrition, stuff like that can lead to that. All right, moving on to sepsis. This is septicemia. So we have flourishing of our microbes in the bloodstream. It could be bacterial or fungal. Fever, obviously, I mean, your body has microbes in the bloodstream and it's going to have an inflammatory response to it. Fever comes with that. It can become very severely high fever because it's right there in contact with your white blood cells, creating that inflammatory response, all over the body, leading to mental state and being declining as a result of that high fever. Obviously, things that would go along with fever. You'll have presentation with GI symptoms. Breathing rate can become increased to the point that you would have respiratory alkalosis. You haven't learned about that yet. Essentially, there's a reason why you have to exhale your carbon dioxide. And if you aren't doing that effectively, the carbon dioxide can build up in your blood and lead to essentially carbonate, which is alkaline. The alkaline effect in your bloodstream, we need to maintain our pH for a reason. We know that helps with our protein function and the healthiness of your body overall. So respiratory alkalosis is something occurring because you're not clearing that carbon dioxide from your bloodstream very well. And all of this can also lead to decreased blood pressure. It's just part of the response and the inflammatory response and the cytokines that are being produced. Again, cytokines are your signaling molecules in all of this immune process. You could have collapse of vasculature, and this can lead to death eventually. We talked about toxic shock syndrome. Those are our gram-positive organisms that can have a similar effect to what we would see with gram-negative endotoxic shock. So endotoxin, we've mentioned it, and I said I'd mention it from day one. I haven't shut up about that or endospore-forming bacteria since then. But endotoxin is lipopolysaccharide, or LPS, present on the surface of our gram-negatives. It's a PAMP, right? So it is something that your body automatically sees as foreign and will react as such. So you will release cytokines, leading to potentially a cytokine storm and inflammation systemically, loss of blood pressure, and the effects of that, all from having just any LPS in the bloodstream. So that's our endotoxic shock. And again, when we see this with gram-positives, we could see a result that is pretty much mirrors this exactly, but it's not from endotoxin. It will be from other toxins from those gram-positive bacteria. All right, the plague. It's a good one. We have 3 manifestations of plague: bubonic, septicemic, and pneumonic. I'm gonna start with bubonic. Buboes, right? So a bubo is an infected lymph node. The tissue within the lymph node itself will be infected. We'll have, pus and necrosis forming within the lymph nodes, and then the presentation of that, which you would see the swollen lymph nodes present from the outside of the skin and potentially becoming necrotic. Those are buboes, so infected lymph nodes. We often see them visibly in the groin region, or it says the axilla, so we're thinking of your extremities here. So you can see the raised inflamed lymph nodes there, and those are the buboes. This is the least severe form of the plague, the bubonic plague. And we think of bubonic plague as being so serious, but it is. It has a very high mortality rate, but not compared to the other two. You get the plague from being bitten by fleas that carry the bacteria, and then they will spread that to people. It's usually maintained in rat populations, and that's how it is transmitted to and from people. Septicemic plague is whenever the bacteria spread and flourish in the bloodstream. So it's going to be a systemic infection in the bloodstream. This is the one that we call the Black Death, because as the bacteria are spreading throughout the tissues, they cause damage, especially in the extremities where blood flow might not be as high anyways, naturally, whether you're healthy or not. And even more so as you become sick with anything. So Black Death, we have a 30 to 50% mortality rate with treatment, but it will be 100% mortality rate if you don't get treatment for it. We eventually have development of necrosis and gangrene from that bacteria and other secondary infections as a result of loss of the circulation to these areas. The tissues in those areas will become necrotic. The toxins produced by the bacteria cause damage, all that compounding and leading to that necrosis. Again, black color of the skin in the extremities, and that's why we call it the Black Death. You have presentation of that, especially back in medieval times when they didn't have any proper medicine. That was what would result. Pneumonic plague is a respiratory version. It can progress from either one of these or be just alone on its own. You can transmit pneumonic plague, the pneumonic version, from person to person. So that is possible. The other ones require transmission from the flea bite initially. So that's something to consider as well. Also more deadly than the bubonic, not as bad as the septicemic. But here's some pictures of some buboes in the groin area of an individual with the bubonic plague. You only really need essentially 3 to 50 bacteria to get in from a flea bite in order to cause bubonic or eventually progression into septicemic plague. Here are incidences of plague here in the United States between 1970 and 2017. This is not a whole lot, right? We don't have a ton of it, but we do have endemic cases of plague here in the United States, mostly in the Four Corners region of Utah, Colorado, Arizona, and New Mexico in prairie dog populations. It's maintained in rodent populations, but here in the United States is primarily prairie dogs. And I don't know if you've noticed, but we have a very high prairie dog population here in Oklahoma. They are very cute. And if you know anybody in Yukon, oh my gosh, it's always a conversation of, what about the prairie dogs when they put up like new buildings and stuff, which is cute. They're cute. Our prairie dogs here do not have endemic plague present in them so far, but we're very close to regions that have it. And so this is something that we monitor for regularly. It is considered a Category A bioterrorism agent. And we've talked previously about how plague doctors would have like the flowers and the herbs in their masks to prevent the smell from getting to them. They thought that's what caused the disease, but that's not it. What causes the disease is a gram-negative bacterium, Yersinia pestis, and that's the bacteria that is transmitted by the flea to the people. Next, we have tularemia. This is another one that is going to be a zoonotic disease, essentially maintained in other populations. Here, high mortality rate, about 30%. We have ulcers that will form on the skin. We'll also have buboes that can develop from this as well. I don't really know what else to say about this, but we do have this present endemically in the Northern Hemisphere in general. It's, again, primarily in animal populations. It's caused by bacterium Francisella tularensis. Mostly rabbits is the main reservoir, but it can be found in other mammals as well. It is a Category A bioterrorism weapon as well. We have next Lyme disease. We know this is transmitted by the bite of a tick, and it's pretty slow progressing disease. Most people will have the development of a bullseye shaped rash associated at the site of the tick bite, but not everybody presents with this. You have fever, headache, feeling sick in general, then you might have stiff neck and dizziness as well. Get some more neurological symptoms that will develop later on, as well as arthritis. Caused by the bacterium Borrelia burgdorferi. It's a spirochete, so it's spiral shaped, has a little hook at the end of it to help it attach to the cells. It can change, Yeah, it kind of does. It's really tiny, though, other than that, and it can get into the cells and make it hard for our body to, deal with it on its own. It's pretty difficult to treat, and it's very difficult to diagnose because it hides out inside of the cells. So yeah. And we think that the immune response to the bacteria is part of what leads to those weird neurological and arthritic developments and inflammation to those guys. But there's not a lot known about it. And it's one of those ones that ends up being a catch-all disease. You have some sort of problems, we can't quite pinpoint it to a disease. A lot of doctors will push for calling it, not a lot, but there are enough out there will push for calling it Lyme disease because you can kind of milk it for treatments for your patients and get a lot of money as, a crooked doctor in a way. So it's actually pretty common. There's a lot of documentaries about this sort of thing if you're interested in looking into it. But it's transmitted by the tick, like I said, maintained in animal populations. And then you go out hiking in nicer weather, get a bite, and you get infected with Lyme disease. Very slow progressing disease, but it's very difficult to treat as well and diagnose as well. Next, we have infectious mononucleosis. You can have mononucleosis. This is essentially dealing with what your cells look like in your lymph nodes due to presentation of certain effects in the lymph nodes, not necessarily always infectious versions. So you can have this without infection, sort of like we can have a lot of diseases that don't necessarily always have to be caused by an infection. But if you have the infectious version, this is caused by Epstein-Barr virus. It is a herpes virus, DNA genome that incorporates itself into your genome. Once you have it forever. We know how mono presents with fever. We have infected lymph tissues, and white blood cells in the lymph nodes are directly infected. And usually it's going to be your lymphocytes that are going to be infected too. So 90% of the world's population has been infected with EBV. Somewhere between 30 to 70% of teens will have had like actual presentation of the infection. That means quite the reverse of those being no symptoms whatsoever when they do get infected. I was one of those. I have antibodies in my bloodstream for EBV, but I've never had symptoms for mono. I guess that's good, but at the same time, it's sort of like when you have chickenpox, it can reemerge. It's not as common as shingles, but I had a student a couple semesters ago whose father would have recurrent episodes of mono from EBV that was latent in his body. We've talked about anthrax a lot in here, and it comes up in almost every symptom because every system of the body, because it can infect anywhere in the body. It just depends on where it's introduced. We mentioned cutaneous anthrax with that black eschar wound that you saw. You can also have pulmonary versions, GI versions, CNS versions on top of obviously cardiovascular being spread throughout the body. So this is always a risk of having septicemic anthrax if you get any of the other versions, because it can always spread into the bloodstream. It is a zoonotic disease maintained in animal populations, so usually it's going to be livestock, caused by bacterium Bacillus anthracis. It's called bacillus, so we automatically know it's rod-shaped. We know it forms endospores, and because it forms endospores, we should also know that it is gram-positive. There are some, yes. So this one is, yeah, exactly. So then we have those two coins of bacillus being the aerobic, and remember Clostridium, our other endospore forming bacteria, is anaerobic. So separate them that way. They make toxins that I'm not going to test you on, but that are very important in the progression of anthrax disease. Next, we're going to talk about the hemorrhagic fevers. There are several viruses, usually RNA enveloped viruses, that can lead to the progression of hemorrhagic fever. So this hemorrhaging, it's just hemorrhaging and fever at the same time. So fever, literally fever. And hemorrhaging, again, we're talking about bleeding out, but it doesn't always have to be external bleeding. It can be internal bleeding as well. So these are almost all of them going to be transmitted by mosquito bite. So this is usually associated as well with, you know, whenever mosquitoes are out in these particular areas, that you're more likely to get them. Sort of like what we talked about with West Nile virus. You're not as likely to get West Nile in the winter because there aren't as many mosquitoes. These are usually transmitted by Aedes aegypti mosquitoes. Some of them are, so these are Aedes aegypti. We have other diseases we'll talk about that are Anopheles mosquitoes. Anopheles and Aedes, both of them we have here in Oklahoma. Have you ever noticed and looked at the mosquitoes that we have in our area? We have some that have like the little black and white spot look into them. And some of them are tinier and some of them are bigger. And so those are Aedes versus Anopheles. We have both of these mosquitoes in the United States, which should be something we're aware of simply because we can house any of these diseases that we talk about. We just may not have them here yet in America, like malaria, which we already talked about, but we have the mosquitoes that can harbor malaria. We've had cases of malaria here in the United States that aren't from America necessarily, but if they're brought here to America, our mosquitoes could take a taste and then continue spreading it on. So that's what I want everybody to be aware of for that. Start with yellow fever. This is not present here in North America. We have this in Africa, South America, in the rainier climates. There is a vaccine for this as well. Dengue fever. This is present in a lot of our tropical areas, and we have had cases of this here in the United States that have come from the United States and no apparent travel outside, mostly in Florida. And I think there might have been a case in Texas, but I'm not sure, but it doesn't seem to be endemic here yet. But it is pretty common. It causes similar symptoms to malaria and is often confused with malaria, but it is viral in nature. Chikungunya is another one that might sound like a completely weird one. It's called break bone fever. We have a lot of pain in the bones and the muscle associated with this one that can persist for years after infection. Started out in Africa, but it had moved later into Central America, and we do have this endemic here in the United States, in Florida and Texas and the Deep South. Presentation of hemorrhagic fever with chikungunya is low. Most people can get chikungunya and have very, very mild to no symptoms and recover just fine. But occasionally we develop that chronic version or the hemorrhagic version. It's just not super common, so we don't hear about it a lot. Next, we have Ebola and Marburg. These guys are not caused by mosquito bites, right? We know this. This is usually blood transmission, fluid transmission. So we have anywhere from mortality rates from 50% up to 90%, depending on the strain, but it does require blood exposure here, or fluid exposure. It can be maintained in like in males who have been infected, even though they can recover from Ebola, they can actually carry the virus in their testicles for like lifetime. So potentially could spread that way and has been documented to have spread that way. Again, they're not presenting with Ebola, but they're just carriers of it. So it's kind of terrifying to think about. But we think the reservoir is bats, and we're not entirely able to prove that. We found some cases, but aren't sure that that's the true reservoir for it. But Ebola and Marburg are very closely related and have very similar symptoms. There is one strain of Ebola that is airborne, known as Ebola restin virus. It's airborne Ebola. I'll say that again. It is present only in primates right now. We found a case of it in Virginia whenever at USAMRIID, which is the United States Army Medical Research Institute for Infectious Diseases. They had brought in monkeys for research purposes. They were being quarantined to be sure that they weren't infected already, because you can't do experiments on infected monkeys. And one of the monkeys happened to have Ebola. It spread to monkeys in other cages in other rooms that were not even adjacent to those rooms. And so they found out that this was an airborne version of Ebola. Everybody that was on the grounds at the time had to be quarantined. There were no human cases whatsoever, but there is an airborne Ebola. Lassa fever, this is associated with multi-mammate rats. So here leads to hemorrhagic fever only in rare cases. Most people 80% people infected are going to be fine. But if you do get symptoms, it's usually pretty severe. So there's our little summary tables for all of that. Moving on to our non-hemorrhagic fevers. So we do have fever associated with this, but we don't have the fragility of our blood vessels that causes them to break and start losing the contents of the blood vessels to other tissues of the body like we see with hemorrhagic fevers. Hemorrhagic fevers are characterized by that blood vessel fragility. It starts out small, and as the disease progresses, we have increased bleeding. But with our non-hemorrhagic fevers, we typically don't have that progression in place. There might be some minor like blood vessel leakage with these, but it won't progress to that deadly effects of hemorrhaging that we see with the hemorrhagic fevers. These are almost all of these going to be bacterial with a few protozoal instances. We'll start with brucellosis. This is undulant fever or Bang's disease. Undulant because the fever itself is going to undulate, go up and down through the progression of the disease. I always get, when I start describing these, I have two of these diseases, I get confused with which ones are present in cows, but the next one is the one. But anyways, you have presentation within various tissues throughout the body of this one. You're going to feel sick. You're going to have a fluctuating fever. It's caused by bacteria Brucella. This is just demonstrating how your fever can go up and down. It can be a very long-term disease, and you might think you're getting better at like day 9 because your fever's going down, but just wait. It's going to go back up. Next, we have Q fever, which is the one that is found in animals and typically livestock. This is Q fever caused by the bacterium Coxiella burnetii. They didn't know what was causing it. It's a very tiny intracellular bacterium that took a very long time to discover. And it's mostly going to be associated with disease in animals transmitted by ticks. It doesn't seem to be associated with human disease, though. It's mostly animals. Next is cat scratch disease or cat scratch fever. This is an actual disease that is transmitted by bites and scratches from cats, 40% of whom carry this naturally. Causes the presentation of buboes, so actual pus-filled infected lymph nodes here. Symptoms will start within 1 to 2 weeks after the bite or the scratch. Most people, when they get this, is pretty mild, but there are people whose immune responses, for whatever reason, lead to the presentation of disease like this. It can have very high fever associated with it as well. I had a patient who was very healthy man who worked with the Air Force, and patient, I meant student. A student who worked with the Air Force, very healthy guy. He got cat scratch disease so severely that he was in the hospital for like over a month to get treated for it. So just depends on how it presents in your body. So that one, cat scratch disease, is caused by the bacterium Bartonella henselae. Trench fever is caused by Bartonella quintana. So it's related, same genus, but different bacterium. Trench fever is carried by lice. So you get bitten by lice that are carrying this bacteria, and it spreads into your body and causes this disease. You have 5 to 6 days of fever, leg pains, headache, chills, muscle aches, and a rash that can develop with this as well, and can eventually lead to endocarditis. Most people will recover from it if given proper treatment for it. This is a huge problem in homeless populations, especially in San Francisco, where we have a very huge problem with homeless populations there. It's called urban trench fever when it appears in those sorts of situations. It's about probably higher, because I know like since these slides were developed in like 2022, and that problem's only gotten worse in San Francisco. I was warned the last time I went to go, because my whole family's from San Francisco. So I went to go visit my grandma. She's like 94, you guys. And she's like at that point where we're like, it's okay, grandma, like it's time. So you start to get to that point. But anyways, last time I went out there for my grandfather's funeral, I was warned when I took my husband out there, because he's not from out there and never seen like Golden Gate Bridge or anything. So I've never really seen the ocean. So we went and did that. Everybody in my family that lives there still, they're all like, yeah, maybe don't go to like 90% of the city though, because it's so much of a homeless problem there. I mean, there was a big issue for a long time of homeless people literally intentionally pooping on people's doorsteps because they aren't getting the support they need as a homeless population to be well taken care of. So not that they always are anywhere else, but it's particularly bad there in certain areas. Where we went at, like, if you guys do go to San Francisco, and I think it's one of the most beautiful cities in the United States personally, but the touristy areas are fine. You know, Fisherman's Wharf and all of that, Golden Gate Bridge. I didn't see any issues with it, but anyways, they have lice with this bacteria. 33% of them have it, and that's trench fever. All right, moving on to ehrlichiosis and anaplasmosis. These are bacteria transmitted by exodes ticks. So the exoded ticks are our hard ticks, so like deer ticks, so the crunchy ones, okay, the little tiny ones. These bacteria are Ehrlichia chafensis and Anaplasma phagocytophilium. You feel sick and you're going to recover usually. That's pretty much it. But these can be transmitted within blood transfusions. So this is something that they will question you about if you do donate blood. Babesiosis is a very similar disease, but it's just a protozoan instead of bacterial. Pretty much what you need to know about it. Now moving on to the rickettsioses. So these are spotted fever caused by rickettsia bacteria, the most common one being Rocky Mountain spotted fever caused by Rickettsia rickettsii. So Rickettsia rickettsii, transmitted by tick bite. These guys are going to lead to chills, being sick and having this rash that usually comes 2 to 4 days after your very first symptoms, aka the prodrome. So you can have the rash. It's a sort of spotted rash that is associated with petechial rash. So burst little blood vessels under the skin. So this is one that kind of rides that like fence of being hemorrhagic and non-hemorrhagic, because the lesions from the petechiae and the damage associated that led to the petechiae can sort of merge and then lead to necrotic lesions on the skin and the vasculature. And so the necrosis can become a problem. You can have cardiovascular disruption, low blood pressure, kind of clotting, and you can have hemorrhage in some cases. So like I said, this is like on the fence between the two. It's a 20% mortality rate if you leave it untreated. It's 5 to 10% mortality rate if it is treated. I had another student who is a paramedic, and she went to a location who it was a very rural location, and there were ticks in the area, and she apparently got a tick bite and developed Rocky Mountain spotted fever. She was in the hospital for a couple months and had very long-lasting sequelae as a result of it. It was very scary. If you know anybody that's actually had this, it's a pretty severe disease. It's a really hard one to get over, and you can die from this. So overcoming that is actually pretty impressive. If you get tick bite and you're like, I think I had Rocky Mountain spotted fever, I think I had Lyme disease, rethink it, because these guys are pretty serious. You probably had ehrlichiosis is probably what you had. But this is the rash that can be associated with Rocky Mountain spotted fever. What else do I want to say? I don't think that's it. Avoid ticks and lice. Okay. Okay, cool. Moving on to Chagas disease. Chagas disease is caused by a protozoan, Trypanosoma cruzi. They test you for this when you donate blood as well. Every person that ever donates blood here in the United States has to be tested for Chagas disease at least once. Here in Oklahoma, for sure. I mean, I used to work for OBI, so I know about how that works. And they'll test you at least once. It's transmitted by the bite of a kissing bug, which is the type of assassin bug. And if you've ever seen like wheel bugs, they're like the gray bug that looks kind of like this. It has like a big old wheel, spiked wheel on its back. Those guys are not this. Okay, those guys are friendly garden bugs. Please encourage those guys. They'll eat the bad guys in your garden. This is not that though. This is the kissing bug, type of assassin bug. He'll bite you, lap up the blood, and poop out its waste. And that's where the protozoa are. They can get in through the skin and through the bite wound. Often they're attracted to eyes and mouths because of, the moisture in those areas. And then inflammation from the protozoa getting into the skin develops into something called a shagoma. So that's the inflamed area where this is happening. Acute symptoms, you'll have that shagoma. You might have feeling sick in general. Then it can develop into a chronic version as well. That's going to lead to heart problems, problems with the brain and the GI tract, and can potentially lead to very severe symptoms associated with that. Trypanosomes have a very characteristic look to them. We talked about the trypanosome. The one we looked at in lab was one that causes the African sleeping sickness. This one is Trypanosoma cruzi. So this is Chagas disease, but they have a very similar look, that little squirrely, squiggly guy there in the middle. They will be found in the bloodstream, and those are all red blood cells all around it. So malaria, we've already talked about this quite a great deal. The signs and symptoms for malaria, again, you usually are generally fine unless you have the bursting of your red blood cells associated with them breaking out. And that can lead to the usual symptoms of just feeling bad. Like you feel really just sore and achy and have fever and all of this. So it will cycle in a 48 to 72 hour interval based on the life cycle of the protozoa in the bloodstream. We talked about a lot of this, so I'm just going to be clicking on through some of this. And that damage to red blood cells can also lead to anemia, of course, and then problems with the spleen, where the parasites can just adhere in there, as well as dealing with just all those damaged red blood cells can cause problems with the spleen, cause it to enlarge and lead to splenomegaly. And then we have the surface of the parasite can change its surface proteins to help evade the immune response as well, which has made it hard to create a vaccine that is like really effective. What we have is it works, but it requires getting it to these rural areas of sub-Saharan Africa where this is a problem, and that's just difficult. So it doesn't work that well. Better options, if you can't get the vaccine, of course, it's going to just be dealing with the mosquitoes themselves. Mosquito abatement with pesticides is one way to deal with it. We have mosquito nets. We have introducing sterile male mosquitoes. Female mosquitoes can only mate one time, and then that's it. They get one shot. So if they mate with a sterile male, then we can help interfere with that process of them populating areas. We often have relief efforts in place from certain groups that will provide mosquito nets to malaria endemic areas so that they can have some protection. If you're traveling to areas that are endemic malaria, they will have you take prophylactic drugs in order to prevent infection. They're usually the quinine-related ones. And yes, that's that. All right, next we're moving to HIV, human immunodeficiency virus. This one, we identified it in the 80s. It was originally identified as a gay-related disease. It is absolutely not that. It is a blood-related disease caused by the retrovirus HIV. AIDS is not the same thing as HIV. AIDS requires that you be infected with HIV, but you can have HIV and not have AIDS. So you have AIDS when you have a certain low level of T cells and you're presenting with opportunistic infections that otherwise you wouldn't have if you had a healthy immune system. So things like this pneumocystis jirovecii pneumonia. So this is something that can develop we only see it in AIDS patients. Certain cancers like Kaposi sarcoma or Burkitt's lymphoma associated with reactivation of having had mono. Weight loss and swollen lymph nodes and loss of immune function overall. That's AIDS. Can happen if you have untreated HIV infection. Again, I think I mentioned it in this class, but if you know anybody that is saying that they are undetectable for their HIV, and that means they don't have to tell you, or that means they're not going to be able to transmit it, that is not true. Just because you are undetected levels of HIV in your blood, that just means that the blood vial that they took, the machine didn't identify that there was any HIV in that blood vial. you can still make HIV virus at any point if it's in your body. And so you should still always consider yourself as infectious. So don't let your patients try to say they don't have to tell people about that to their sexual partners and stuff. It's gross as a person. Of course, you can keep HIV at undetectable levels and have little to no symptoms at all of having HIV, and that is great, but you should still use protection, right? And still be open with your partners about that. So HIV and AIDS. You might have some minor issues associated with HIV infection, but it's again not AIDS until we have that low T cell count and introduction of those opportunistic infections. And it just gets worse and worse as far as other effects of not having an immune system, essentially, as that progresses. A retrovirus, again, it's called retro because not because it's retro like in the 50s or something, but retro because you can take your RNA genome and turn it into DNA, which is the reverse of what we're used to. That reverse transcriptase, along with integrase that incorporates that DNA into your genome, and the protease that the virus makes to clip its translation product into the usable proteins are all great targets for drugs for treating HIV. The most common type of HIV we have is HIV-1, but there is another one, HIV-2, that is possible. Did you know that 50% of all sexually active aged individuals in South Africa have HIV? 50%. That is astounding. That's a lifetime infection. That's the truth too, and that is absolutely terrifying. But anyways, we know how HIV works. It's going to incorporate itself in your DNA, and at any point it can make new virus from the dormant. So this is transmitted by blood. Sexual transmission, they believe, is mostly associated with, yes, sexual fluids, but also with micro tearing in tissues during the sexual process. And then we have breast milk being a transmission fluid as well. Urine, tears, sweat, and saliva are not sources of infection. We think 38 million people are infected worldwide. 1.2 million infections exist in the United States that are diagnosed. And 15% of people in the United States, 15%, that's more than 1 in 10. It's 1.5 out of 10, but 15% of people in the United States are unaware that they have HIV. That is also terrifying. That's the United States. All right. We diagnose this with ELISA, which we've mentioned previously, agglutination tests with antibodies, and rapid antibody tests as well. So again, we talked about diagnosing AIDS being a low T cell count and presence of certain opportunistic infections. You want to avoid sexual contact with people who have HIV and use barrier protection if you are having sexual contact with people who have HIV. We now have drugs available like PrEP that are going to be prophylactic in a way if you're having sexual contact with people who do have it to prevent the spread. If you're going to share needles with people with your heroin, please bleach your needles first. And then clinical trials are in place for vaccination, but this is a very highly mutating virus, so it's really hard to keep up with for effective vaccines. So usually have combinations of antiviral treatments we'll give to help attack those three main targets of the reverse transcriptase, integrase, and the protease. That's our summary for our cardiovascular system. We're already at 11:17, so I'm gonna, I probably just should make like a worksheet for you guys that has all these questions for this chapter that we haven't been able to go over. But I'm gonna go over these really quick. Yersinia pestis causes the plague. Which organism causes Lyme disease? That's Borrelia burgdorferi. How is trench fever transmitted? That's lice. What type of organism causes malaria? Malaria is a protozoal infection. HIV, what does it use reverse transcriptase for? To turn its RNA genome into DNA so it can be inserted into your own. All righty, any questions? I'll have a little bit of a break before we go into the lab review, but we'll do that right here. Yes, ma'am. Yeah, so it does. It causes basic general sickness symptoms, usually high fever, like a lot higher than what you would see typically with flu or colds. So higher fever, it's a longer lasting, usually it's 2 weeks to a month, if not even more than that. depending on, each person. But yeah, it's more severe version of the flu and also typically located in the actual, like lymph nodes and stuff like that. So you'll have really swollen lymph nodes. They'll be very tender. So that's another sign that it's different than the flu. But yeah. The unknown, yeah, changes for the unknown project. If you got comments on it last night, early this morning, yes, you can make updates up until Wednesday at midnight, except for if there's a blank. If there's a blank that you got left blank, then I have to give everybody no points for blanks. That's because of assuming that people just didn't complete it, and then we're hoping to get full credit for it later. But yeah, any other changes or updates to like the content itself, if I made a comment about that, those can be submitted until midnight on Wednesday.
Whenever you said vascular trauma, is that like if you have
So with vascular trauma, we're more talking about like if you get a bruise, right? There's ruptured blood vessels there. So actual trauma and damage to like blood, like vessels. Yeah, that's okay. Yeah, you could imagine that if you have something like asthma, the inflammatory reaction involved in that could have some like low level vascular trauma involved in that response because it is inflammatory. And we know inflammation causes tissue damage. It could relate to having vascular trauma as well. So it just depends on how your body is reacting and how bad that asthma attack is too. Yeah.
the second time